Good afternoon. I am Christiana Lok, and it's my pleasure to participate in this conference. And I was asked to tell you something about surgical treatment of trophoblastic disease. We will talk about primary and secondary curettage and the indications for a hysterectomy. Then I will explain something about removing metastasis from different organs, and fertility-sparing surgery is getting more important, so we will talk about it as well. And there are options to prevent surgery, like chemotherapy or uterine artery embolization. So we will shortly discuss it, and then we get to the take-home message. So curettage is actually always the standard first surgical treatment when you suspect a woman from having hidatidiform mole pregnancy. We prefer to do it ultrasound guided to get a complete evacuation of the disease from the uterus. You can use cervical ripening because it does not increase the risk of gestational trophoblastic neoplasia or widespread disease, but you should give it just before surgery and not repeat it several times. With this kind of curettage, you often have a little bit more blood loss than with the regular curettage, so it's good to inform the anesthetist about it and to have a serum cross-match ready. The risk of complications is not very high. The literature reports an incidence of perforation of around 0.6%. You should send tissue for histology to confirm your suspicion, but also to know the type of molar disease or to know whether there's a choriocarcinoma or placental site trophoblastic disease. And in rhesus negative women, you have to give NTD. These are also the advices from the European Organization for Trophoblastic Disease. Their guidelines were recently published in the European Journal of Cancer. After the curettage, you have to do a HG follow-up, and there are some different protocols in different countries. But we stated that you should at least perform it 2 weekly until the serum HG has dropped to normal. And then with partial mole, you have to confirm that it has normalized, but then you can stop follow-up. And in complete mole, you should continue for about 6 months before you can discharge the patient. If the HCG does not normalize and there is a plateau or even an increase, you can have gestational trophoblastic neoplasia. Sometimes you can do a second curettage, and there are a couple of studies published. One of the first studies was from my colleague Nienke van Trommel. She analyzed over 2,000 patients, and she found that a cure occurred in 1 out of 10 patients after second curettage. So that's not that much, but there also was a debulking effect. So less MTX courses were necessary. Instead of 6 courses, these women after second curettage needed 5 courses. There were not many complications. 1 in 50 patients had a perforation. There's another study, which is a prospective study from Ray Osborne, and he included patients that developed GTN and had a low risk GTN, and 60 patients were enrolled and underwent second curettage, and then the HCG was monitored until normalization. And in this series, 40% of all the patients normalized with the second curettage, and 60% needed additional treatment. And then, of course, we have a randomized control trial, which is quite special in trophoblastic disease performed by Dr. Hamida. He randomized 89 women to either a non-surgical treatment or a second curettage. These women all had HCGs below 5,000 units per liter, and there was a stratification for HCG in a group with higher HCG than 1,500 and a group lower than 1,500, but all patients received MTX. And he did not find any difference between the groups in follow-up and needing additional treatment. It's difficult to translate this study to the rest of Europe because we don't give standard methotrexate after second curettage. But if you do want to know whether your patient with an HCG below 5,000 has a chance of cure with a second curettage, and you do give MTX, these are very valid data. I think there, although it was not clear from this study, there might be a debulking effect because the women with higher HCG had more benefit from the second curettage, although not significant, than the women with lower HCGs. So possibly if more women were included or higher HCGs were included, the difference would have been significant. So in summary, the advantage of a second curettage is that there is a possible debulking effect. In some women, it will lead to cure. It does provide additional tissue for diagnosis, and we know that sometimes there is a transformation to choriocarcinoma, to PSTT or ETT, or even a mix between those two tumors, and there's not a high risk of complications. So it's something you can discuss with your patient. Another option is to perform an hysterectomy. You can do it when there's a lot of blood loss and curettage is not an option and there's no other possibility to stop the bleeding. If you have a patient that does not want to have a further pregnancy, and especially if she's over 40 years old, it's also a very valid option. If multiple lines of chemotherapy have failed and there's still a lot of tissue in the uterus, hysterectomy can be a part of the treatment. And of course, hysterectomy is a standard treatment for PSTT, ETT, and we will come back to that later. In a Dutch study from Jalk IJsbouts from 2017, a cure rate of 48% was found after hysterectomy. You can perform a total laparoscopic procedure, but you have to know how soft the tissue of the uterus is, and otherwise you can always convert to an open procedure. She also found that treatment after hysterectomy is much shorter, so it's 3.2 weeks instead of 8 weeks, and also less courses of chemotherapy were necessary. But it's still important because some women do need chemotherapy after hysterectomy to perform HCG follow-up. Another study, which is from the French team, also studied hysterectomy in women with low risk gestational trophoblastic disease, and they found even a rate of 73% cure after hysterectomy. The difference between this study and the Dutch study is probably a different selection of patients, and the French study only included 30 patients. But it definitely shows that hysterectomy is an option for some women who do not want to preserve their fertility. In PSTT and ETT, as stated before, hysterectomy is standard. In ETT, you always have to realize that the tumor can be quite low in the uterus, in the lower uterine segment, and sometimes even growing into the perimetria. So sometimes you have to perform a radical hysterectomy, and a standard hysterectomy is not sufficient. There can be lymph node metastasis, but this is quite rare. So standard lymph node dissection is not necessary, but you have to look at imaging to see if there are enlarged lymph nodes. And if they are enlarged, you have to remove them. The study of Smith in the Lancet more than 10 years ago already showed that there is a 3.2% of lymph node metastasis in PSTT. We do the hysterectomy because PSTT and ETT are less sensitive to chemotherapy compared to choriocarcinoma. And also in advanced stage PSTT and ETT, a combination of surgery and multi-chemotherapy is often necessary to achieve a complete cure. There are some fertility-sparing options, and we will discuss that later. Prognostic factors for PSTT and ETT are the presence of lung metastasis, stage, and the interval. In the guidelines of the EOTTD, the treatment of PSTT, ETT is lined out, as you can see on this slide, and it definitely depends on stage. So in stage 1, and not a very long interval, at least less than 48 months, hysterectomy is sufficient. If the interval is more than 48 months, that's a very high risk of recurrence, and you should consider at least adjuvant chemotherapy. In stage 2 and higher, chemotherapy is necessary to achieve a cure. Free surgical margins are very important. And as said, you sometimes have to do a radical hysterectomy. A laparoscopic approach is allowed, and it can be necessary to perform genetics to see from which pregnancy the PSTT or ETT is derived from, and you needed to confirm the interval of the pregnancy. Something that's a little bit newer, and we don't know it for many years, and Basit probably has explained it already in a previous presentation, is the atypical placental side nodule. It's a benign lesion, and the atypical placental side nodule shows atypical features in a placental side nodule. And it's important to make the difference because 14% of the cases of APSN are associated with malignant gestational trophoblastic disease. HCG is not reliable because it's often not increased. And if you suspect a patient of having APSN, it's wise to ask for review pathology, for example, to the Charing Cross, to do additional imaging examinations like pelvic ultrasound, contrast MRI, and you have to repeat hysteroscopy and biopsy probably several times. So if there is a child wish, you have to perform this at a regular base and consider fertility-sparing surgery. But if the child wish has been completed, you should consider an hysterectomy. We decided to register all these cases in the PSTT database as well to learn from it together. Salvage surgery is used when chemotherapy alone is not enough. You can perform it in low-risk GTN when there's localized disease, but also in metastatic low-risk GTN, and then you will achieve a remission of around 100% without even needing multi-agent chemotherapy. In high-risk GTN, it can be useful in selected patients. You can imagine if there's widespread disease with a lot of lung metastasis, that only a salvage hysterectomy will not cure your patient. But if the metastases are can be removed as well, or the volume is small, it can help to reach cure in a combination of chemotherapy and hysterectomy. And overall, the cure rate with these combinations is between 83 and 88%. Other sites of metastasis can be, for example, the lungs, and you can perform a pulmonary wedge resection by either video-assisted thoracoscopy surgery, a FOTS, or by performing a thoracotomy. It's only useful if there is still vital tumor. You can confirm that with either a biopsy, but it can be tricky because it can sometimes bleed quite severely, but also if you have a good tumor marker like HEG. So if the HEG has normalized and you do see abnormalities on CT chest in the lungs, you often do not have to remove them. Patients with disease at multiple sites, so not only in the lungs or with many lesions in the lungs, are less likely to benefit from these lung resections. Another way for salvage surgery is a laparotomy. This can be to control bleeding from like the liver or the spleen or the kidney. But also if there's just one remaining lesion, to remove it and to achieve normal HEG value. Brain metastases are luckily quite rare, but it can occur in high risk and ultra high risk disease. And then sometimes you need to ask the neurosurgeons to perform a craniotomy, either to manage intracranial bleeding or to resolve intracranial pressure issues. And sometimes a localized metastasis can be removed, sometimes in combination with chemotherapy or stereotactic radiotherapy. The cure rates of brain metastasis are in quite a wide range of 50 to 85%, depending on very much other prognostic factors as well. Because it always concerns young women, or mostly concerns young women, you try to perform fertility-sparing surgery. And case reports or very small case series have been described where local uterine wedge resections are performed combined with uterine reconstructions. It's only for very selected women with localized non-metastatic GTN. It's only described as a primary treatment, so not of recurrence, and it's often only 1 or 2 patients in case reports. Many patients, especially the patients described with fertility-sparing surgery in PSTT, still require afterwards a hysterectomy because the surgical margins were not free or it was not possible to localize the PSTT. Myometrial excision of invasive moles are described, but 32% still need postoperative chemotherapy. And then it's always the question, wouldn't you have achieved a cure with only the chemotherapy without taking the risk of removing a part of the uterus? But if there's a big bleed and you need to stop the bleeding, then a wedge resection can be helpful and necessary. There is always the challenge of localizing the lesion. It's difficult to estimate the amount of resection needed to achieve remission, and imaging can be helpful, but it does not always correlate that well with what you find during surgery. You should make really sure that there are no distant metastases. You can use frozen section to make sure that the surgical margins are free, and you still need to do HCG follow-up. So in general, these procedures, if you want to do it, you have to counsel your patients very well, and the patients most likely to benefit from it are the patients with low HCG values and small lesions of maximum 2-3 centimeters, and definitely not metastatic disease. You can try to prevent surgery, of course, with chemotherapy. You can start monochemotherapy if there's low-risk disease with either methotrexate followed by dactinomycin, and there are many countries who start with dactinomycin. And recently we also have pembrolizumab as one of the options. This is mostly given after multi-chemotherapy has failed, but there is now a French study who already gives it to women failing on monotherapy. Multi-chemotherapy schedules, there are several, and they can be very helpful in preventing surgery. Then we've got a selective angiographic embolization, especially to control hemorrhage. This is often successful, and intervention radiologists are really skilled to perform this. It can either be the uterine artery, if there's a bleeding from the uterus or the vagina, but also other localizations are possible. In these two photos, you can see a bleeding in the liver. The upper photo, within the circles, you can see that there is blood coming out of the vessels. And in the lower picture, you can see that it has stopped completely. And if you look really well, I'm not sure how well you can see this on screen, but there are 2 coils in the vessels. So the bleeding has been stopped by the intervention radiologist, and the laparotomy was not necessary because the bleeding from the liver was stabilized. And this particular patient was cured with multi-agent chemotherapy. The embolization is also used for angiographic embolization of intrauterine arteriovenous malformations, which can occur after the treatment of GTD and GTN. So with this surgery, but in combination with chemotherapy, we are able to achieve cure rates of 100% in low-risk GTN, more than 85% nowadays in high-risk GTN, and at least 50% in ultra-high-risk GTN. So this is my last slide, the take-home message. Ultrasound-guided suction curettage is recommended for the treatment of ETT4 Mo, followed by HCG monitoring. Second, curettage is not standard. It has a low risk of complications, and in selected cases, you can discuss it with the patient. Hysterectomy can also be considered in selective patients, especially in chemo-resistant disease or older patients. It's still the standard treatment for PSTT and ETT. Resection of metastatic lesions in the lung or brain can be considered in patients with isolated chemo-resistant tumors with metastasis, and selective angiographic embolization can be used to control hemorrhage or treat intrauterine arteriovenous malformations occurring after GTN. So thank you very much for your attention, and if there are any questions, I'm very happy to answer them.